Susie Enel is not with us. She has another meeting, and so she was not able to join us, but I'm going to deliver her talk. So the name of this session is the New Therapeutic Options for Neurogenic Bladder Dysfunction. And in the past years, we've witnessed an incredible amount, I would say almost an explosion of new options, new way of stimulating, new way of placing the stimulators, the leads, and the new indication for it. So I'm going to guide you through these new targets for the neuromodulation. We're going to talk about neurogenic bladder and pain. And let me introduce Michele Spinelli, who's going to follow me. He's, besides being a close friend and a colleague from a former colleague of mine, we used to work in the same country. He's actually the one who taught me how to do neuromodulation. Thank you for giving me the opportunity to improve your technique. All of his patients were crying in pain when we did this together. And Michele is currently chair of the spinal cord unit, and neurourology in Niguarda Hospital. This is one of the major hospitals in Milan. Another very interesting guy sitting on my left side, Nucelio Lemos, is another very close friend, and this friendship came through ICS. We worked very close together, shoulder to shoulder, to build a great program that you can enjoy during this meeting. We started this in Rio. And Nucelio it's also very interesting because he approaches the neuromodulation and all these very difficult topics from a perspective of a gynecologist. So Nucelio is, I would say, one of the few gynecologists that know anything about the innervation of the pelvis, of the female pelvis. He is a little bit limited because you work, but you do guys as well, correct?
Yeah, I work with men too.
And so he is chair of the, what is the name of your, this
pelvic neurodysfunction
pelvic neurodysfunction clinic. This is a new way to collect these patients, and there are very challenging patients with neurodysfunction. As I said before, this goes from any neurological, any dysfunction of the organ in the pelvis and pain. Susie, as I said, is not here, so I'm going to deliver her talk. Those are the slides from Susie. She is a neurourologist based in London, and she is sending her apology because she is currently presenting at the FIGO meeting in Vancouver. Those are her disclosures, and I have to say are coinciding with mine one as well. We used to stimulate almost every part of our body, from the brain down to the pelvis, for several diseases, as you can see here. We go from neurogenic disorders like epilepsy, depression, tremor, dystonia, spasticity, problems in the function of the organs in the pelvic floor, from the bowel to the bladder. We are going to focus mostly on these lower, so pelvic organs in this. We know that, and actually this is a known fact from the history of medicine. There's a guy named Scribonius Largus, and a colleague of Michele and I from Rome, a couple of thousand years ago, used to start the stimulation, used to start the electricity to address some of the problems. The funny thing is that the list that I showed you before included all of his indication. So he was using electric eel, walking the patients over this, and he was treating everything from depression to problems with bladder emptying. The interesting thing is that the cells use electricity, mostly electricity, to talk with each other. And if we interact with this electrical signaling, we can actually use this from our therapeutical goals. This is just a number of implants done in the patients treated with modulation, neuromodulations. And we have some challenges in what we are doing currently. We have some problems in how to permanently fix the leads that we are implanting. The leads should be as close as possible to the nerve that we are stimulating, because if this is not the case, that we are going to drain the battery, and we will have to replace and do a very costly procedure for the patient. We need something that is lasting longer compared to what we have right now. Those devices can break. Even the leads can break if you have a non-proper positioning of the lead. And there's some electromagnetic interference, which can represent a major problem for the patient. The battery life is another issue. It's very easy to say for us as a clinicians, oh, this is not a big deal. You just go back a few years from the day of surgery, and we're going to replace, we're going to give you a new battery. But each time that the patient goes under any procedure, it's a major distress. So that's something that we can work on, and we need some improvement in the future. Plus, the things that we are implanting in our patient interacts quite significantly with the other field of medicine. Just thinking about the diagnosis and the inability of a majority of our patients to undergo an MRI evaluation. The programming is also so the way how we are interacting with the implanted device. It represents also a challenge. You need special devices to be able to interrogate the stimulator, to be able to manipulate the parameters and to improve the outcome of the surgery. We've seen in the past quite a few devices that are not longer available. This is one of those devices. I remember coming here to the States to be exposed to this, while I was still in Europe, to be exposed to this Bion stimulator. Great idea. So you'll be implanting a stimulator close to the pudendal nerve. You're going to recharge this from outside. The patient will be sitting on a special or laying on a special device that is going to recharge the battery of this stimulator. But from great ideas to good and permanent results, the journey is pretty long. And they actually failed to produce those because there were some huge problems in recharging those batteries. There was even worse problems when this device needed to be removed. So this is no longer available. But as I said before, there are a lot of new things going on. And those are basically the paradigms that we have to accomplish if we want to have a successful model of a new generation, the 3.0 generation of neuromodulation. Something that is small, something that is friendlier for the patient and for the implanters, and lasts, if not forever, for a significantly longer time. We have some problems. We have some problems with the quality of the leads that we are using. We have some problems with the fixation of this because the vicinity to the nerve is very, very important. And we, as I said before, we have to have something that is that we can use other investigational diagnostic like MRI in our patients. So having something that needs to be changed every 3 to 7 years is I don't think it's a good long-term solution for our patient. So we should aim for new, longer-lasting batteries and translational science from industry, I don't know, from the car industry. They are just working now on the new rechargeable batteries based on hydrogen. This is just something that Toyota, for instance, started recently to investigate. They're just about to launch a new electric car based on this. So we have to look broader to our the technology that we're using. So something that lasts at least 15 years would be a good goal. Something that's compatible with MRI and something that is easy to manipulate. Those are the problems that we encounter. So the patients shouldn't be connected to a wire, for instance, during the testing phase. Shouldn't be actually be implanted with something during the testing phase. It would be ideally having something that can stay outside of the patient's body, that you can test the nerves, you can test the responses that those nerves can have, and then go for one implant. Those are just a few of the new companies and products that we have or we are going to see in the near future. Some of them, I don't think that any of them has proven the test of the time. We have a pretty big lack of evidence for this, but this is where the trend goes. That's why Susie decided to put them here. You can stimulate, for instance, or modulate the nerve activity, stimulating the vagina, through this FEM pulse, where you can try to achieve some improvement in the OAB symptoms and in the or when multiple pelvic organs are involved in this pelvic floor dysfunction. You can try to modify the technology for the neuromodulation through this. This is another example of the quadripolar tine but flexible leads for a sacral neuromodulation with a smaller pulse generator and something that is easier to operate or to communicate wirelessly. You have new innovation in the tibial nerve, posterior tibial nerve stimulation, where you can actually, rather than just implant or stimulate with a needle, you can implant a needle close to the tibial nerve, and then having a generator which can be recharged, trying to obtain the same stimuli. The question, and this is the end of my introductory talk, is where should we implant our leads and what should we stimulate? So I'm going to leave the podium to my colleagues and friends